So, good morning. I just want to say from the outset that I am not a data scientist, but what I am is a surgeon that has been applying informatics to try and come up with solutions for problems that we have as surgeons for some time. And I'm very interested in specifically the postoperative space and what happens after patients go home. Um, these are my children. We recently went to Appalachian State, where the older one, who's wearing the maroon T-shirt, goes to school. He's becoming a fermentation scientist. The one on the left is interested in computer science. And as we were walking through the library, we saw this huge display, this digital display, that there was an AI symposium in the library that day. And I know you're probably not going to be able to see this, but this is articulated in how many different ways AI is basically permutating, integrating, infiltrating colleges. So all the things that we're talking about here are happening in every aspect of society and in education. And how do we use it? We're all just trying to figure it out. So it's everywhere. And this is really where I'm interested: acute wounds, users and their data, mHealth, and the intersection of how analytics can help us with communication, decision-making, care coordination, and public health, population health. This is what I've been doing in my whole career. And way back in 2015, I worked with some brilliant data scientists. Patrick Sanger was a PhD student that presented this, and what we basically were trying to do was to figure out, is there a better way to identify when someone is developing a surgical site infection? And his conceit was, typically we're using these baseline features to predict whether or not someone is going to have a problem. How long the operation was, whether or not the patient's smoking, whether or not the operation was contaminated. But in fact, what we really want to look at is, in the days before the wound infection develops, all of these different factors that come into play. Have they been tachycardic? Did they have a fever? Was their wound temperature elevated or lowered? And what impact do those events leading up to the day of the diagnosis have on that development? And can we construct models that are looking at day -1, day -5? And so the hypothesis was, if we incorporate this daily wound data, it would improve the accuracy and timeliness. And if you look at our predictive model, I mean, a lot of these things are fairly simplistic now, well beyond this in terms of methodology. But the fundamental idea of looking at repeated measures and trying to figure out how we can lay those into a model to predict was really where we were. And what Patrick was able to show was, in fact, even 4 days before the day of diagnosis, you can see on this line here, this is day 0. This is when the surgical site infection was discovered. And you can see there's a very wide range between symptom numbers between those that didn't have an SSI and those that did, but it goes all the way back to day -4. So 4 days before, we could see some signal that these patient populations were diverging. And looking more specifically at each of the elements, you can see that there were certain things that were good, better, or best at actually discerning these two populations earlier and earlier. So the classifier performance, interestingly, the baseline features, not a great performance. The repeated features, a little bit better. But interestingly, you add the baseline features and the repeated features, and it doesn't really improve the model that much. So are we looking at the wrong things? Are we anticipating that someone is going to become sick and they actually will not? And so I think, looking at this, the poor predictors of surgical site infection are erythema, wound pain, amount of induration, warmth, and heat. Wow, that sounds like what we usually use to diagnose surgical site infection, doesn't it? So if you look at the SSI category C from the CDC, and now this is from 2015, it's been updated since then, but these features still remain. So greater than 80% of both SSI and non-SSI patients had bright red skin surrounding their wound. So how reliable are these criteria? So can we improve on this diagnosis is really the question. And so we developed this, and I'm showing this to you. This has never been a commercial product, so I don't have any conflict of interest here. This was always a research project. We developed this idea to create a tool that would allow patients to follow their own wound when they went home from the hospital, send us photographs, and do a simple survey of symptoms so that we could determine whether or not they were developing an infection. So why isn't everyone using this now? I mean, it seems perfect, right? So I'll tell you why. We created this before telemedicine was cool. It was way back, 5 years before that. We had no EHR integration, and it was a lot of work, teaching, monitoring, and getting people to accept that this was a new way to communicate with each other after patients left the hospital. We also had a tremendous amount of bias that we did not realize when we were creating this. We spent a lot of time doing a needs assessment. We based the platform on the experience of surgical practitioners, not just surgeons, but APPs and nurses who take care of patients who have wounds. And then we only asked patients who had developed SSIs what they wanted. We didn't ask regular patients who had had a pretty typical postoperative course. So we created this tool for the people that were having problems, not for everyone. And at the end of the day, I think the biggest problem that we had is that we fundamentally demonstrated that there's a workflow conflict. Patients want to know if they're okay. They want you to contact them. They want you to say, yes, that's exactly how you should look today. And we don't prioritize this type of communication because we don't have time. There's a wonderful book that Eric Topol wrote in 2019, anticipating a lot of the things that we're talking about right now. And it's called Deep Medicine. The last chapter is actually quite prescient. It's an emphasis on deep empathy. So what we really want as people that care for others, as human beings, is to have a connection with the person that's sitting in our office or sitting on the other side of the screen or laying on our table. We need to have a connection with that person to be able to make our humanity continue. And so if we get time in our encounter to be able to actually look someone in the eye rather than type into a computer, perhaps we will be able to have another opportunity for that kind of connection. This paper has already been presented this morning, but I want to emphasize it in a different light. This is the Kaiser Permanente experiment, their pilot with using ambient AI to create documentation during the clinical encounter. Their accuracy was actually quite good. And we heard some about hallucination, and you can see that this AI chat, this AI scribe program actually was almost free from hallucination in this spider plot. And I'm just going to emphasize that what this gave these primary care doctors back was time. So time outside of 7 a.m. to 7 p.m. and time spent in notes during appointments, meaning that that time that you and I have looking at each other in the eye is a human time, not a documentation time. It's a time to answer questions. It's a time to look and see those nonverbal cues that your patient is scared, apprehensive, gonna walk out, don't like you. How do you fix those things if you don't look them in the eye? So the impact on patient-surgeon relationships is tremendous. What do we uniquely bring to the relationship? Can we leverage this time that we have? I don't carry around maps in my car anymore. I don't plan my trip anymore. I use Google Maps every time I get in my car. Is there anything wrong with that? It allows my brain to do something else. However, I think we're going to uncover that we have a bigger problem, and that is that we are not very good at communicating with people. This was a wonderful study comparing physician and artificial intelligence chatbot responses to patient questions. This was done via Reddit. There was a random draw of 195 exchanges of questions that were public questions where a physician responded. And then they sent out the same question to a chatbot and had an independent panel review the responses. And I'm not kidding, this floored me. Look at the quality and empathy scores for each of these comparisons. The chatbot outperformed us. Think about this. Your patients want you to ask them if they're okay. So can we learn from LLMs to deliver better perioperative care? And are we ready to accept that feedback? Could the LLM tell us, coach us, you're not doing this very well? Here's a better way to say that. Just in the last second that I have here, the president has put out this executive order for 14110 in October about safe, secure, and trustworthy development and use of AI. And now that I work for the federal government, I receive messages from the VA, and I was very excited to get this just a couple of weeks ago, and this message talking about this order and how the VA has responded to giving us some education on how to use AI in our work. Except I can't get to ChatGPT from work. Thank you.
Thank you very much.